We are live. It's Dr. J here in the house with Evan Brand. Today, we're going to be chatting about blood tests that we use to help assess our health and help us get better. So we're going to be chatting a little bit about kind of intro blood tests, what the best tests are, kind of what our perspective on that is. Evan, how are we doing today, man?
Doing really well. Excited to dive into this topic. I went and got my blood work, and I got my wife's blood work done on Friday. And I just want to give a brief little note on how you and I run blood work as clinicians, because it's very easy and it's so convenient, because we don't have to go and beg a GP or an MD and say, hey, please, doctor. I mean, you and I've heard countless stories. Yeah, I asked my doctor to run this, they wouldn't run it. I asked my endocrinologist to run this, they wouldn't run it. With us, the accounts that we have with our credentials, we're able to order and create customized lab panels. So you and I both have created customized blood panels that with a click of a button, we can go boom, order it for anyone, whether it's ourselves or our clients or patients. And then we get an instant requisition form. We go straight into LabCorp request. You check in, you sit down, they call your name, you hand them the paper, you get the blood draw, you go home. It is so amazing. Every time I get my blood work done, I'm like, wow. And I didn't have to get anyone's permission to do that, but my own.
Isn't it nice? Yeah, it totally is nice. Also, there's the big insurance scam, right? So because we have accounts directly with the lab companies, we can order tests, and typically we get, an 80 to 90%, um, discount in price compared to what the insurance would bill. So like my typical thyroid panel, full thyroid panel that I charge my patients, probably around $120. And the insurance would typically charge a patient for that well over $1,000. So then most patients don't get 100% coverage, right? Especially if you're not in network, and then the doctors can't ever retest but once every 6 months. So then you're stuck not being able to ever retest, but they think, oh, I'm going to get coverage for this, and then they get 90% coverage, and they end up paying more money for the 90% coverage, even though if they paid 100% cash, it'd have been cheaper. So that's kind of the insurance scam. And then the problem with that is they can't retest but once every 6 months. So they're kind of stuck. So yeah, it's really nice to be able to order what the patient needs and to be able to reorder and reassess based on a time that is good for us, not good for the insurance companies. That's kind of nice.
Right. Yeah. And we're kind of circumnavigating that conventional system where you're waiting 2-3 months and then you get a bill in the mail and you're like, uh-oh, medical bill, what's this about? And then it's like, oh, you owe 700. With us, it's all transparent. It's up front. You pay, boom, 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 you're done. I've already paid for it. I know that I'm not spending another penny. And the turnaround time is insanely quick too, like 1 to 2 days typically on some of these panels are running. So let's go into some of the details. Now, let's quickly compare and contrast. I think you and I have a lot of fun, like where we did our conventional functional medicine versus conventional medicine gut workup. Let's talk about the same with blood work. So if you go to your doctor and you have them say, hey, Johnny, we're going to run your blood, what is that going to look like?
So a conventional medical doctor, they're typically going to do a CBC. They're going to do a metabolic panel. They'll probably do a lipid panel. And that's usually going to be it. Maybe a urinalysis. That's kind of it. So like on the CMP, they're kind of looking at liver enzymes. They will look at some electrolytes on the liver on the CMP as well. Those are liver enzymes, electrolytes, maybe some protein markers there. They'll probably look at glomerular filtration, kind of some baseline kidney function with creatinine and BUN. The liver markers are going to be ALT and AST, the liver enzyme markers. The gallbladder is GGT. They'll probably look at some bilirubin. Your electrolytes are going to be sodium, chloride, potassium, magnesium, all serum, not intercellular, which is a difference, okay? And then on the red blood cells, they're going to look at red blood cells, RBCs, hematocrit, hemoglobin. That's part of the CBC, right? Complete blood count, which is going to be helpful for anemic patterns, right? Low iron, right? They'll also run indices, which are MCV, MCH, MCHC, right? Mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration. When those markers go high, that tends to mean that we're dealing with B vitamin issues like B12, folate issues, and we call that megaloblastic anemia. So we have two kinds of anemias we look at. Big cell anemias, right? We tend to be more B vitamin stuff. And then small anemias, which tend to be more on the red blood cell, hemoglobin, hematocrit, low iron side. And then we have immune markers, whether it's neutrophils, lymphocytes, eosinophils, monocytes, and basophils, which could be from bacterial issues, parasite issues, gut inflammation issues, viral issues. And then I would say on top of the CBC, that's pretty much it. And then your lipids. So total cholesterol, triglycerides, And then, of course, your LDL, VLDL pattern. And then there's some add-ons that we may talk about, whether it's C-reactive protein for inflammation, fibrinogen for inflammation, homocysteine for inflammation and methylation, vitamin D. And we can kind of go into each one of those in regards to what we think is important on the functional side. But, the whole lipid thing is it's kind of overplayed, right? People think that lipids are a really important issue now once you start going over 200 or so on the total cholesterol, and that may not be. And we'll talk about the ratios and the perspective that we add to it when we look at it.
Yep. So the way you talk, it sounds pretty good. It's like, oh, wow, that's a lot of stuff. But truthfully, there are rarely issues that show up on just standard blood work. Now, if you have more of the functional training that you and I've had regarding blood chemistry, you can kind of, I guess you would just say, pick through the CBC with a fine tooth comb, and you can really look and maybe find some functional issues. Like for me, I know that for a very long time, my hematocrit, I've always had the hematocrit be a little bit high, which based on some of the training you and I've had, it would indicate that there's probably a dehydration issue. And that's tough. It's tough to stay hydrated. And so even if I'm sipping on water all day, but I've heard there's a big influence on anti-diuretic hormone and all of that when you're exposed to mold toxin. That's a conversation for another day. But anyway, unless you're really looking with a fine tooth comb, conventional blood work doesn't reveal much. And you may see a little bit of this, a little bit of that, but I'm not making too many protocol decisions based on a CBC, I would say.
Yeah. So when I look at blood, it can give me a good area where to look next or where to dive in deeper, which is helpful. And then if we look at it using the optimal reference range or a functional reference range, we can definitely glean better information. So the problem with most conventional medical doctors, they're looking at blood through a pathological range. They're trying to pick up like major disease patterns or pathological patterns. And so how it works is you have all people kind of fit in what's called the bell curve. And the typical range is going to be 2 standard deviations to the left and right. This represents about 95% of the population fit into the so-called normal. So you have 2.5 on the high, 2.5 on the low that are on the high or low side pathologically, right? And so the problem with that range is as people get more unhealthy and sicker, and as those sick people tend to test more, what happens to the lab reference range over time? It gets wider. And so it becomes more encompassing. It's like having a bad field goal kicker, and you make the field goal every year wider and wider and wider and closer to compensate for the lack of good kickers out there. So it's kind of like that. And so what we do is we kind of narrow up that range a little bit, and that narrower range helps us pick things out before it becomes a problem. So let's kind of go over a couple of things. So with women or people that are vegan vegetarians, women, because they bleed more when they're at menstrual age, right? Typically 50 or below, 48 or below, they can be more anemic. So we may look at things like lower red blood cells, right? Red blood cells, below 4.2 or so. We may look at hemoglobin below 12. We may look at hematocrit, in the mid to low 30s as a sign that there could be some low iron issues brewing. We may also run an iron panel that's not typically run. Like we may run things like ferritin or iron binding capacity. Or we may look at things like iron saturation to get a window of low iron, for instance. And that's commonly missed because what most conventional docs do is their threshold for low iron is really low. And so there's a lot of women I see, and vegetarians in general, that could be on that lower side, could be a little bit anemic, and then they're not going to be able to carry oxygen throughout their body adequately, which makes a huge difference in energy and stress and mitochondrial function and thyroid function, because you need to be able to carry oxygen to have good energy.
Yeah, let's go into some of the more let's break some of the stuff down, but before we break it down more, let's hit on what are the things that we're going to run. And so I've got my panel pulled up that I ran. And so I'll kind of run through some of these things. But as you mentioned, ferritin, that's typically not going to get run. I've rarely seen ferritin run by anyone. The iron saturation, as you mentioned, the iron binding capacity, that's rarely run. That's going to be TIBC, often on your blood work. The vitamin D, I mean, my God, it's so important, but yet vitamin D to this day is still not commonly run.
Nope.
And if they run it, they may run the wrong one. I've seen people where they don't run the 25 O-hydroxytryptophan. They're going to run like the D2. They're going to run the, what is it, ergo Yeah, the
Ergo,
vitamin D2.
yep, ergocalciferol. Yep,
Yeah,
that's
ergocal.
correct. Yeah, so
So
you
if you
have
say
the
vitamin D, they may run the D2, and you're like, crap, I needed the
yeah.
D3.
Yeah, the cholecalciferol is the animal based, kind of the D3 is the more active form. The D2 is the more plant synthetic form, typically made from lanolin a lot of times. That's the D2, that's the ergocalciferol. So vitamin D is really important. And then the range on that is pathological as well. They want above 20. Why? Because they're looking for rickets, right? The bone bending disease, right? Because D3 helps absorb calcium and helps the calcium get into the bone. So we want 50 to 70, or maybe 70 to 100 if we're autoimmune or cancer risk. So vitamin D is a big one. I would say also on the CBC, we may be looking at immune cells. If I see low white blood cells, below 4.5, there could be some immunodeficiency issues. If it's high white blood cells, greater than 7.5, there could be some immune stress. Now we look at the immune cells. How do we look at those? Never let monkeys eat bananas. That's the mnemonic device in doctorate school we learned. So neutrophils, we want to see, below 60. Lymphocytes, we want to see mid-reference range. When we see high neutrophils or low neutrophils and elevated lymphocytes, that's a common H. pylori or bacterial infection pattern. If we see elevations in eosinophils greater than 4, we're thinking potential parasites or chronic environmental allergies. If I see monocytes greater than 10, I'm thinking some kind of intestinal inflammation. So there's different, patterns we may look at when we look at some of these immune cells. That's very important. But unless it's very high, they're typically not going to say much. And if it's very low, they typically don't say much either there.
Yep. So also more advanced thyroid markers. It's very, very sad how many people go to even an endocrinologist and they may only end up with a free T4, possibly a free T3, but even that's not guaranteed. Maybe a
Mm-hmm.
total T4. You may get, of course, TSH is going to be on there, but you and I are definitely going to be running like thyroglobulin antibodies. We're going to be running TPO, thyroid peroxidase antibodies, maybe TSI sometimes if we think there could be something else going on.
Correct.
And then you've got the uptake of T3. What else you got? You got reverse T3 that we're going to be looking at. That's an awesome marker, and that's never run.
Yeah. So when it comes to a thyroid panel, you already mentioned it. Most conventional endocrinologists in primary care are going to run TSH because that's the major screening brain hormone, not a thyroid hormone, may I add you. It's not a thyroid hormone, but it's the major brain hormone that talks to the thyroid. And you'd be lucky to get a T4 total after that. But we know downstream is a lot of conversion issues. And even patients that have normal TSH, guess what? Especially if they're on Synthroid, which is a synthetic thyroid medication that's just T4, many of them can't make that conversion. And that's a problem too. And so you can have adequate T4, good TSH, and low T3, and you may have a lot of thyroid symptoms. So it's really important that we look at things complete. And don't even get me started on thyroid antibodies because that's almost never run. And thyroid antibodies are the major mechanism why most people's thyroid glands aren't functioning properly because their immune systems have beaten the crap out of their thyroid for a very long time.
Yeah, we're talking what? I mean, you'd say probably over half of cases of hypothyroid are probably autoimmune based on what I've seen. What would your guess
Yeah.
be?
Yeah, I would say that. And some may not even come back on the lab test, but it's very helpful to be able to look at those. We run TPO antibodies and thyroglobulin antibodies. And so my full thyroid panel is have some kind of a TSH, T4 free in total, T3 free in total, TPO antibody, thyroglobulin antibody, and we may run a reverse T3 or an uptake. Those are all okay markers to add too. So that's kind of your complete thyroid panel. Let me just piggyback to the CBC. Is there anything else on the CBC? I think we hit it all there. We can go to the metabolic profile now if you want.
Yeah, well, you mentioned like earlier, like C-reactive protein. C-reactive protein, I guess it kind of depends. I mean, sometimes that's standard, but a lot of times that's not. And then HSCRP is, going to be the same section of the inflammation panel on your blood. So hopefully you get those two run together.
Yeah, usually CRP and cardio CRP is basically the same thing. CRP, they're breaking the number down typically below 2. I think the cardio CRP, they typically don't do it less than 2 or so. So when you do a highly sensitive CRP, they're just breaking it down into a smaller number. What's good? We want to see that below 1. That's great. It's a good marker of systemic inflammation. And fibrinogen's great. If we are for highly inflamed, we may see a lot of clotting happen. And fibrinogen looks at clotting factors, which is helpful. So if we don't have good fatty acids, good omega-3 to omega-6 ratio, or a lot of inflammation, a lot of trans fat, high blood sugar, cells tend to agglutinate. They get very sticky. And so it's nice to see where that stickiness level is. And homocysteine is also another measure of blood inflammation because It's homocysteine is an inflammatory metabolite that typically happens when there's not enough B vitamins, B6 and folate and B12 in their active form. That can be a big inflammatory issue there too.
Yeah, that was a problem for me actually. I did have elevated homocysteine a couple years ago, and started hitting some more folate, and it fixed it. So it was fun to see how the blood correlated to that.
Yeah, and we're going to try to get as much of that as we can through leafy greens and high quality, essential fats and meats, right? But that's good. And so metabolic profile, we may look at liver enzymes that could be helpful. Patients that have a lot of insulin resistance and inflammation, you may see an elevation in liver enzymes. What does that mean? That could be a non-alcoholic fatty liver, non-alcoholic steatotic hepatitis. That's NASH or non-alcoholic fatty liver, meaning your liver has stress not from alcohol, but from typically too much fructose and junky carbs. And so the liver people think the liver is just a big filter for toxins. No, it also has a major effect at regulating blood sugar and is also a storage site for sugar, especially fructose. So when you overconsume fructose from high fructose corn syrup or just too much carbohydrate in general, the liver really gets stored up. And then when that liver fully gets saturated, overly saturated with fructose, for instance, you start having all these upregulations of inflammatory enzymes called the junk enzymes, the JNK1 enzymes, and you see a lot of inflammation in a fatty liver there, and you see it on ultrasound. And so that's a common marker of seeing those elevated liver enzymes, and it's good to be able to look at that.
Yep. I don't know if you've tested blood work much with people like in the middle of a protocol, but I've had a couple interesting cases where while using binders, we've seen liver enzymes go up. And it could have been also parasite protocols and things like that that were kind of interwoven with detox protocols. But I've seen liver enzymes temporarily go up during that. So I don't know if you've paid much attention to
Yep.
that, but I've seen it, and they always go down as soon as the protocol's over. So
Even with some killing herbs, like wormwood's a common one that we may see a little bit of elevation in liver enzymes. People that are sensitive to some of the killing herbs, it could be a little bit of stress. Is it just the herbs, or is it the dead debris that is now mobilized from the killing of those microbes? It could be both. That's where adding things like binders can be very helpful, just to kind of put handcuffs on those critters and escort it out of the body versus kind of having it go back into general circulation. Also adding an extra glutathione support can be helpful too, just to really support and tonify the liver. Those are very important too.
yeah, well, and it's common for you and I to use some sort of a liver gallbladder support too. So we may be throwing in like some extra taurine or methionine or beet powder, artichoke, and there's many, many things. Did I say milk thistle already? NAC. So there's a lot of stuff we can do. But yeah, I just figured I'd mention it because if someone's listening and you happen to do blood work in the middle of a protocol, it's possible that the levels you may look at them and go, oh my God, my liver enzymes, but it will go back to normal relatively quick after a killing protocol's over.
Exactly. Also, we may look at glucose. Blood glucose is going to be on a metabolic profile as well, a CMP panel. I don't love it as much because most people that are going to get a blood test and they're getting pricked in the arm with a big needle, are they kind of stressed? Yeah. And so that the cortisol from that can really increase their blood glucose. So I like getting a really good blood sugar kit like this, and then you can measure your blood glucose during the day. So here's my little kit here. And so I use the Keto Mojo now because it measures ketones. So I have my little meter, I have my little pricker here for my finger, and then I have the blood glucose and the ketones. So this one right here is the blood sugar, and this one here in the lighter blue, this is my ketones. So it's kind of nice to have those so I can test my blood sugar before I eat, and then I can do a 1, 2 hour, 3 hour and play around with my blood sugar. The whole goal is the more you keep your blood sugar down after a meal and bring it back to baseline within 2 or 3 hours, the less insulin you're making. The higher it goes up and the longer it takes to come back down, the more insulin you're making. So it gives you kind of a good window of how you're responding to food.
Yeah, what I wanted to point out is that you're doing more functional analysis of glucose versus if you just go into your doctor once every 6 months, you get a morning fasted glucose. It's not enough information.
It's not, because the whole goal while you're checking morning glucose is because you're thinking your food's so out of whack that your glucose is now elevated as a result. Now, the problem is most people haven't eaten in 12 hours. So for your glucose to still be out of whack 12 hours later, the problem has to be pretty severe, number one. And then number two, a lot of times it can be elevated not because of food, but because of stress hormones in the morning. And so the stress hormones, people say, oh, I'm at 105. Yeah, but it just could be a good cortisol response in the morning called the dawn phenomenon that's raising that glucose. That's why you want to check it against your foods during the day. Because if you have a blood glucose issue, you're going to see 1 and 2 hours later, it's chronically elevated and it's taken a bit of time to come down. So that's a better marker to make sure you're handling glucose okay.
Yep. How about hemoglobin A1C? This is something that for diabetics, obviously, this is hopefully going to be regularly checked. But for your average person that maybe has some issues, A1C is probably not going to be on your standard blood panel.
I don't love A1C. I used to like it. I don't love it as much. I find that when people's blood cells live longer because they're more healthier, they have more time to accumulate blood glucose. So the A1C, it's a part of the hemoglobin, and they're looking at the coating of glucose on the outside of the hemoglobin, right? So imagine like, when you go up into your car during allergy season, you can see like a big thick swath of like pollen on the car. They're kind of looking at the swath of glucose on the outer part of the hemoglobin. Now, the problem is the longer your red blood cells are hanging around, the more time they have to accumulate that blood sugar. So it can be helpful to look at something, but if you're a little bit on the higher side, or like, let's say 5.5 or so, let's say under 6, but 5.5 and up, it may just because your red blood cells are a little bit more healthier. So like, for instance, with my anemic women who may have a ton of blood sugar, right? A lot of carbs because maybe they're vegetarian or vegan. Guess what? When you're anemic, your red blood cells die faster. So all my anemic women have A1Cs super low, like in the 4s. And so it's not going to be a great marker when your red blood cells don't live that long. And we see it with our anemic patients.
Yeah, that's a good point. Good point.
It's good to
Mine's
look at though.
always
If I see someone 6 or higher, yeah, it's helpful, But when you're kind of in that subclinical zone, you're going to typically have to go back to a meter like this to really look at it, and then also look at your fasting insulin, which is a better marker because that's going to give you a better window of how much insulin you're making frequently.
Yep, good point. That analogy is perfect. The pollen on the car. So good job there.
Right, and if you leave your car out there a lot longer, you're going to get a lot more pollen. It's kind of like that,
true.
right?
I'm always under 5 though, no matter what with A1C. I'm always right 4.9, somewhere in there.
Yeah, I'm pretty low too. I'm always like right in the low 5s, 5.1, 5.2. But I've seen a lot of patients in my career that have really good diets, that have tested their blood sugar, have good insulin, and they'll still have a little bit higher on the A1C. And I'm just like, yeah, it's missing some people. That's all.
Makes sense.
And the question is, what's the mechanism? And that's what it is.
Yep, makes sense. You hit the dawn phenomenon. So, cortisol that may be run via blood, although we don't really like blood cortisol too much. We really like more functional analysis of cortisol, like with urine or possibly saliva.
Oh yeah, and part of the reason why we don't like it is just because when you're measuring a stress hormone while creating a stress response, i.e., putting a needle in my arm, you may influence that a little bit, right? And so that's kind of the reason why we don't love that. And even if you're like, well, do the adrenals make cortisol fast enough after the needle happens to show in the blood? Well, it's not just that. It's the fact that you're anticipating it happening. Therefore, you're replaying that stress in your mind all the way up to the doctor's office, going in the elevator, getting into you're already making that stress hormone while you're anticipating what's going to happen.
Yeah, you go in the friggin' lab with the scientific fluorescent lights above your head. It's all awkwardly quiet. They got some like drug commercials on in the waiting room. Justin? And they call your name, come on back. Yeah. So, and, also not to mention too, that's just a snapshot, right? I mean, that doesn't tell us anything about what's happening at 2 or 3 p.m. when you're complaining of that midday crash. So I really am not too interested about what happened at 8 a.m. I really want to know, well, what's going on at 2 p.m. when you're saying you need that 3rd cup of coffee?
Exactly. Yep. 100%. So it's really important that you're kind of on top of that. So I think we hit some good blood glucose stuff. We hit some liver enzymes. We hit, I'm thinking here, we hit some of the electrolytes. So electrolytes are good too. So sodium and chloride are really good ones. Now, when I see patients that have adrenal issues, you could easily have low sodium and high potassium, or you could just kind of have lower minerals altogether. Now, the serum is not going to be the best marker for testing minerals. So when you see your minerals out of balance, you know it's a big issue, but you could still have mineral issues and the serum be okay, because it really matters what's in the cell, not necessarily what's floating around in the blood. So think of imagine you're in a pool. Okay. The pool is serum. Okay, you're in the little floaty, you're in the little inner tube, right? So it's you in the inner tube, right? You in the inner tube and the water in the inner tube, that's intercellular. The water outside of the inner tube is extracellular or serum. So that's kind of how you think of it. So when we test some of these nutrients, it's better to get a sample of the water in the inner tube with you. That's intercellular versus the water outside of the inner tube. That's serum.
Yeah. And how do people get that? What does that look like?
Well, you can we can add like a red blood cell serum or a potassium serum on some of these panels. We may run like a SpectraCell or a NutriEval or an ion panel that looks at more intercellular nutrients. We may look at different tests that allow us to do that, but there's not too many add-ons for conventional testing like Quest or LabCorp. Outside of I've seen red blood cell magnesium's good. You can do a potassium if you wanted. So there are a couple that you can do to get a window into that.
Yeah, that's what I was going to say. I looked through all the options for the conventional labs, RBC magnesium. I think that was about it. I think that's all I could find. So,
Yep, not too much, but it's something, because magnesium's a big one, right? And with magnesium RBC, we want to see it greater than 5 on that one. Red blood cell magnesium greater than 5. So that's helpful. And then, of course, we mentioned magnesium serum. We want that greater than 2. And then your minerals, you want them somewhat mid-reference range. Once we start going under 100 or so, I think like sodium, it's like 104 is kind of mid-range. If you're under 104, it could be a problem. Potassium, I forget the exact ranges in it, but I want them all about mid-range in regards to the reference range.
what do you
But
feel
you could,
about
yeah.
what do you feel about using conventional blood work to do like omega-3, omega-6 fatty acid panels? I know there's some docs that are just so obsessed with all these ratios, but truthfully, if you're doing the things that we're discussing with our clients and patients for nutrition, you're going to pretty much be optimized anyway. I don't know what that would tell you besides, hey, maybe you need to do a little more of this or that.
Yeah, it's a great question. I think look at the person's food. Like someone could have a really good diet, but let's say the meat and the eggs aren't pasture fed. Well, that could easily be the reason why your omega 6 to 3 is off a little bit. Or it could be that, you're just doing too much plant fats, and those plants are coming from, omega 6 based plants, soy or canola or safflower. So if you're doing good fats like coconut oil and olive oil and avocado stuff, which are monosaccharides, or so those are monofatty acids versus a poly, which is like a fish oil, right? And then so the fish oils, you have omega 3s, right? Which are going to be like the ones that we talking about that are going to be more on the anti-inflammatory side, right? These are the polys. And then of course the omega 6s are going to be more on the vegetable side. These are going to be also polys, but they're going to have 6 bonds. These are going to be your safflower, your canola. These are going to be your soybean oil, all of your plant-based fats. Most of your plant-based fats, to extract the fats from them, with the exception of olive oil or maybe an avocado, you tend to have to damage the fats. So they tend to be more damaged. They tend to be more on the omega-6 side. And when you eat plants by themselves, you're not getting that concentration of fats. And so you tend to not have that high omega-6 to omega-3 when you're doing just vegetables by themselves. Okay. And so we can just look at how much fish you have in per week, how much pasture fed eggs you have in a week, how much steak or meat that is grass fed you have in per week. And then you can kind of look at it relative to what's high on the omega-6s, like the nuts and the seeds and the refined vegetable oils. And you can kind of get a pretty good assessment of where you're at, which is like kind of 4 to 1 or less. So 4 times omega-6 to 1 is pretty okay. And you can always run that omega-3 to 6 test on the blood too. Does that make sense?
It does. Yeah. I just find that it's not a huge needle mover. So I don't run it too often. I mean, I think it's cool to check in. You could call it kind of a lie detector test because if somebody says they're doing everything that's dialed in, but then you find out that, oh, they've been cooking a grass fed steak, but it's been in this healthy heart oil blend that they found on the shelf. And it was a safflower canola combo. You're like, oh, crap. Then we missed it and you got to get off of that stuff. So,
Yeah. I mean, yeah, go ahead.
I was just gonna say, so it's not really a standard thing for me, at least. I'm not running it too
Nope.
often with people, but it's there. It's an option. And then
It's something if someone wants to run, we'll run it. And so we have the polyunsaturated, which is the fish oil or on the omega-3 side, right? And then we also have things like flaxseed oil, but it has to get converted to the higher up fatty acid. So, omega-3 fish, and then you're going to get some omega-3 from cows that are grass fed as well.
What about particle size on a lipid panel? Should we talk about that briefly? That's
Yeah.
just a good add-on that most people don't do. And our friend Jack Wolfson, he discusses particle size, and I think it's something that more people are asking questions to their doctor about, but it's still very uncommon to run.
People that have a cardiovascular history just want to run it to begin with. I think it's okay. I can almost always tell you what your particle size is. If you're eating good, healthy, saturated fatty acids like coconut oil and grass fed butter, and you're getting meats that are like good quality fish, good quality grass fed beef, egg yolks, you're keeping a lot of your junky fats down, a lot of the refined sugar down, and a lot of the trans fats down, you're going to have a particle size A, which means large and buoyant and fluffy. All right. Think of A like you want an A on your test. And then you have the small, dense atherosclerotic particle size B. Think B for bad. And the B for bad, more trans fats, more inflammatory processed vegetable oils, more refined sugar. And so with patients, I almost always can look at their diet and guess what that will be to begin with. So if I do a dietary check and do a diet recall, what's the average day look like, and I look at that and I get a window, it's pretty easy to predict that. And so we'll run it for patients that have a cardiovascular history and they just want to know, but for the most part it's not hard to predict it.
Yeah. And when you see it, are you just tweaking diet? Like if you see a bunch of small, dense particles, or are you coming in, are you using any kind of like plant sterols or anything like that to help with it? Or are you just tweaking diet and then it fixes itself?
It depends how acute the patient is, but if it's not acute, meaning the patient's not dealing with a heart issue right away, then we're going to just tweak the diet and that's going to take care of it. We're going to add in extra omega-3 fatty acids from fish oil. We're tweaking the diet. We're getting the carbs down. We may be adding extra nutrients to manage blood sugar and manage inflammation. And then usually within a month or so, you're going to see a big change after we retest.
Awesome.
Yeah,
Yeah.
usually once you get about 100 good meals in, you're going to see a big shift, right?
Sweet.
Because
That's a
the
good
average
number.
person is doing about 21 meals a week, right? So 3 a day times 7, 21. So 4 to 5 weeks. Once you get 100 meals in, and if you can get them close to in a row, your body has a huge shift in physiology.
It's amazing
Huge.
how quick you can change stuff. I mean, sometimes we get impatient because, like, with the detox piece, like that takes longer. I mean, I am a couple years in detoxing mycotoxins. I've still got some going on. So, with that, it's like, oh man, you get impatient. But luckily with the blood, it's a quicker turnaround time, it sounds like.
Oh, totally, man. It's really important. So I think we hit some of the big markers today. Oh, I would say one other one for lipids. I don't really care if cholesterol is a little bit on the higher side. Just I try to make sure the cholesterol to HDL ratio is ideally, 4. So if your trigs are sorry, if your total cholesterol is 200 and your HDL is 60, well, what's that ratio? Do the math, pull up my calculator, 200 divided by 60, that's 3.3. That's pretty darn good. Usually when you're under 3.5, that's half the average risk factor. Okay. Let's say you were at 240 divided by 60 on the HDL, now you're at 4. And so I like to look at the total cholesterol, the HDL, because HDL is what recycles cholesterol. Okay. So if you have good recycling lipoproteins, i.e. HDL, that's a good sign. And then I'm also going to look at my trig to HDL ratio. We want that under 2, but if we can have it closer to 1, that's wonderful. What does that mean? Take your trig number. Let's say your trig number is at 60. Let's say your HDL is at 50. Well, what's that number? Well, we do 60 divided by 50. We're at like 1.2. That's good. So we want it under 2, but closer to 1 is ideal. That's a really good marker. That's my insulin resistance inflammation marker for my lipids. So I look at trig over HDL. That's a really good marker.
Yeah, I talked to Jack one time about the blood, and I said, when do you start getting freaked out regarding total cholesterol? Because if you talk to a conventional cardiologist, they're brainwashed on that 200 number, and he says that he's got people up in the 450s that he's not worried about 1%, like total cholesterol being 450, and it's not an issue. So he just talks about, like you said, ratios, inflammation associated with it. Then you get into more trouble. But I mean, the total number, I mean, he acts like it's just minimally important.
Yeah,
On its own, on its own.
I would be a little bit concerned once you start getting in the mid 300s, just because that could be more hypercholesterolemia, and that's not necessarily a diet thing. That's more of a genetic thing where you're making a lot more cholesterol. So I personally would get a little bit more concerned with that, and I'd be monitoring that. But it's hard to really jack up your cholesterol when you're keeping inflammation down. Like I just did a blood test for my lipids last month, and my cholesterol, my total cholesterol, and you know what I eat, man. Good fats, good proteins, good eggs, good fatty acids, and my total cholesterol was at 165.
Whoa. Yeah, mine was like a 202. So
Yeah, 165. My trigs were at 60 and my HDLs were at 50. So I had like a 1.1, 1.2 ratio for trig over HDL, which is great. And so most of the cholesterol you're going to have is going to be made by your body. So when it starts getting too jacked up and your diet's good, we want to look at thyroid hormone maybe. That could be a big thing. And there could be a hypercholesterolemia genetic issue. And we can always run a genetic test for that to see what's going on. And if that's the case, what are natural things you can do to get your cholesterol down? You can do higher dose berberine to make sure your thyroid's checked. You can also do some potential plant sterols as well. But get that checked. So my philosophy, if it goes a little too high, I'm curious. I'm worried about the hypercholesterolemia piece.
yeah, and I don't
Genetic.
mention that 400 number just to get people off the hook. I just thought it was interesting that that's what he was saying, and he's
Yeah.
probably talking like you're in big trouble if you get to that point. But anyway, so
That's
yeah, I
rare
think
though. That's super, like these are very, very rare situations. Sub 1% of the population are going to be there.
I've never
Most
seen it
people,
ever.
I have two patients with that, but most people already know about it because someone in their family already had been picked up previously.
Yes,
So
yes.
most people already know about it, especially today, maybe 30, 40 years ago, not as much, but people that have had those issues have already been picked up. They already know genetically if it's in their family. And then once you know genetically if it's in their family, they tend to get tested for it.
Yep, right. Well, let's wrap this thing up. So,
Yeah.
as we mentioned, blood work is a piece of the puzzle. If you go to a practitioner and they're like, I'm going to analyze your blood and tell you everything you need, they're wrong because you mentioned some of the clues into the immune section about parasite infections and all of that. However, I will speak for you and say that you're not going to depend on that blood work solely to identify parasites. You're still going to be running comprehensive genetic DNA-based
Bingo.
stool panels. You're going to be running organic acid panels to look in deeper. So, yes, you may look at those things, and I think it's awesome that you gave us some insight into that. However, I'm not going to go to a guy who's going to look at the blood and say, yep, you've got parasites. Let's put this protocol together. I'm going to want more data. So blood is just part of that data. And it can be helpful, especially when you're working with autoimmune people, because you and I like to look at these antibodies and it's very fun and satisfying. And it makes you look better when you could have a woman come in with a TPO of 1,000 and all you do is fix her gut and her TPO antibodies go down to sub 200. That's exciting.
Totally. That's huge. So I think today is great podcast because we're talking about actionable things. We want people to kind of like say, hey, what's it like to be inside Dr. J and Evan's head? And this is kind of it. And everything that we look at, we're kind of like a detective. We're putting like check marks in a column over here that support us going in this direction or going in that direction. So we add up all of our check marks, right? And we're kind of create what that differential diagnosis is and what tests we're going to do to dive in deeper in whatever those avenues where those check marks are adding up. So that's kind of inside of our head. We're walking through our thinking. And if you want to dive in and reach deeper, into work with a practitioner like Evan or myself, you can head over to evanbrand.com. You can schedule a consult with Evan or myself at justinhealth.com. And you can schedule. We are available worldwide to help y'all with your functional medicine and natural healthcare needs. And if you want to get to the root cause, we're going to be the best person to look at. Evan, anything else you want to highlight here today?
Maybe just one frequently asked question. Well, I'm not where you live. Does that matter? Well, in the US, it doesn't matter at all. We can run like a comprehensive blood panel. We can run that anywhere. Now, we'll try to help people internationally in regards to providing maybe some codes or things like that to help people. But at least for the US, no, location does not matter. We haven't had any issue with that. I think New Jersey for a while was getting a little more strict, but beyond that, no, I mean, nationwide, it's a piece of cake. So as we talked about in the beginning, create a panel, send a requisition form to your email, print it, go get your labs drawn, you're done. It's awesome.
100%.
Was it New
All right,
York
today,
or was it New York or New Jersey? Was one of them?
yep, both.
They're both difficult, but was it for blood or was it for some of the functional? Or
For
was it
blood,
both?
for blood, but there are still some mail-in finger prick tests that we have accessible to deal with patients like that. So we still have options for them, maybe not quite as much. And then if they're near the Connecticut border or the Pennsylvania border, we have also options there too. But we still have some mail-in stuff that's helpful.
Cool. All right. Well, check out the sites, justinhealth.com, evanbrand.com. We'll be back next week. Take care.
Excellent. Have a good one, y'all. Take care.